Hi, and welcome to Fit for Fellowship, a survival guide for the first-year general cardiology fellow. I'm Megan Pelter.
I'm Stacy Sy, and today we are going to be doing our session a little bit differently. We will be collecting your questions via email for Dr. Held's talk on pacemaker basics, and then we will forward your questions to Dr. Held, collect her answers, and then we'll again post at a later time the recording of the answers to your questions. So please go ahead and email us your questions, and we'll collect them.
Fantastic. So let's move straight on into Dr. Held's presentation. Dr. Elizabeth Held is an electrophysiology fellow at Cedars-Sinai Heart Institute in Los Angeles, California. She's originally from Washington, D.C. and completed her medical school and residency at Emory University and Vanderbilt University Medical Center, respectively. She then moved to Los Angeles for cardiology training at Cedars-Sinai, where she served as chief fellow. She is interested in cardiac arrest prevention and is passionate about fellow and resident education. So she has a very exciting and important talk today, and we look forward to hearing it.
Hi, everyone. My name is Elizabeth Held. I'm one of the EP fellows at Cedars-Sinai in Los Angeles. Today, I'm going to give a lecture on pacemakers and ICDs on call. And let's dive right in. So today I'm going to go through a couple basic pacemaker ICD concepts that will help you survive your first night, first week, first year on call. I'm going to start pretty basic, maybe a lot of stuff you already know, but hopefully move beyond that a little bit and get everyone feeling pretty comfortable with interrogations, with devices 101, basics of a device interrogation, what to do if you're called to the OR, and some sort of basic guidelines to how to place a transvenous pacemaker. So first, let's go over implantable devices 101. Again, starting fairly basic, but moving beyond this. So a pacemaker, what is a pacemaker? It consists of a pulse generator, which is a power source or battery, and then either 1, 2, or 3 leads or wires that go into the heart. These are fixed, as you can see on the right here, either with an active fixation lead or a passive fixation lead on the right. And that wire is how we get the electrons from the pulse generator to the myocardium to tell the heart to pace. This is basic anatomy of a pacemaker. Some basic terminologies to start. So first off, single chamber devices, dual chamber devices, BiV devices, CRT devices. A single chamber device is just a pacemaker or I suppose an ICD with either one wire in either the RA or the RV. A dual chamber, 2 wires, one in the RA, one in the RV. BiV ICD and CRT devices are essentially the same term. CRT is the more modern terminology, but they're essentially the same thing. This is for cardiac resynchronization. You have 1 wire in the RA, 1 in the RV, and then there's a 3rd wire placed in the coronary sinus in an attempt to get it around to a lateral branch to pace the LV for resynchronization. If it's CRTD, it means there's a defibrillator, CRTP, pacemaker only. I'm going to introduce some other less common types of devices that you may see. First is an SICD, otherwise known as a subcutaneous ICD. This is a device that's placed in the chest wall with a defibrillator lead that's tunneled just over the chest, generally reserved for younger individuals or those who have vascular challenges to placing a standard transvenous ICD. And then second, a leadless pacemaker. I'm sure everyone will be seeing this more and more over the next, we've been seeing a lot of this and more over the next coming years, about 2.5 centimeters long, implanted via the femoral vein directly in the RV without leadless, so no wires, no RA, RV wire, everything's contained in that one device. Next, you may see these terms, his bundle pacing and left bundle pacing. These are rather newer methods to achieve cardiac resynchronization via conduction system pacing. So you either, as you can see up in that top picture, have a lead at the location of the His bundle, or in this bottom picture, across the tricuspid valve in the high RV septum, essentially drilled across the septum to the left bundle to attempt to directly pace the left bundle. And you will certainly see plenty of TVPs and perm attempts. TVP, temporary transvenous pacer, which is a balloon temporary pacing wire placed via central line, which we'll talk about later in this talk, and perm attempt, which is a regular pacing wire implanted in the RV or sometimes RA with the generator left outside the body and not implanted. This is considered more stable than a TVP. The patient won't need the ICU, and essentially serves as a bridge to a permanent device if there's some sort of temporary contraindication, such as infection, or you're waiting a bridge to deciding whether the patient needs a permanent device. It's important to know how to identify a device on chest X-ray. You can see here on the left is a chest X-ray of a single chamber pacemaker. There's the pulse generator up in the left chest with a single wire traversing the subclavian vein, the SVC, down into the RV apex here, or RV mid-septum. As opposed to what you see on the right, which is a dual chamber ICD. And you can see a single wire in the right atrial appendage, and then a second wire in this is a higher RV septum device. And the key difference between a pacemaker and ICD on chest X-ray is that you can see on an ICD, there's a coil, which is sort of a thicker and it's a more thicker appearance on imaging. All right, let's go through some of the nitty gritty. This stuff can get kind of dry, but it's really important for being able to do an interrogation. We have a standard classification code of 5 letters that was established many years ago as a universal way to describe pacing modes. In position 1, you have the chamber pace, and this is generally A, V, or D, meaning the atrium and the ventricle. Position 2 is the chamber that's sensed, again, A, V, or D. Position 3 is the response to sensing. And you'll see this is either I or D. I meaning that if the device senses an impulse, a native impulse, that it'll inhibit itself and not pulse. D meaning it will inhibit and trigger. So it will inhibit itself if it sees a native beat. However, if it doesn't, it will pace the heart. And finally, and in the 4th chamber, you have the various programmability settings or rate modulation. This is really only used to essentially to mention rate modulation that can adjust the heart rate in response to patient activity, and this is denoted by an R. You generally don't use the other letters here. And finally, this fifth letter code is really rarely used, so I wouldn't worry about it. Let's go through some quick examples. So this here is an AAI, a strip with an AAI pacemaker. You can see the first 3 beats are an example of atrial pacing. The patient is set at AAI 60, meaning that pacing the atrium. They sense the atrium, and then if atrial beat is detected, pacing will be inhibited, as you see in the latter half of the tracing. Here, this is an example of VVI 60, meaning there's only a ventricular lead. Here, they're being ventricularly paced, but when an intrinsic ventricular beat is sensed, pacing is inhibited. And finally, here is some strips from a DDD pacer. You can see in the top left that the pacemaker is sensing atrial activity, but pacing the ventricle, so A-sense, V-paced. On the right here, or below that, you can see A-sensed, V-sensed, meaning that there's native atrial and ventricular conduction, and so the device has inhibited itself. Whereas on the right, you see A-paced, V-paced, AV sequential pacing. All right. It's also important to know some key terms about pacemakers before we get going into how to interrogate someone. And these key terms are sensing, impedance, and threshold. So sensing is the minimum, or sorry, stimulation threshold, or threshold is the minimum electrical stimulus needed to consistently capture the heart outside of the heart's refractory period, meaning how much power how much voltage do you need to administer in order to capture the myocardium. And this is generally expressed in voltage plus pulse width, so how long the stimulus is delivered. And here you can see on the left, you have a pacing stimulus, but no capture, but capture. And on the right, you have pacing stimulus, but no depolarization, so non-capture. Impedance is the sum of all resistance to the flow of current, meaning it shows the opposition to current flow. In the pacing system, impedance is measured in ohms, and generally normal is around 300 to 1,000, and we use this mainly to look for stability. Very large fluctuations in impedance or drops or increases can suggest lead malfunction. And finally, sensing. So sensing is the ability of the pacemaker to see when a natural intrinsic depolarization is occurring. It's sort of like the fence. If we set the sensing to a particular level fence, if the intrinsic beat is lower than that, then the pacemaker won't see it. And if it's higher than that, then the pacemaker will detect that impulse. And you can see in this example, the sensitivity setting, this fence here is set such as the pacemaker will likely sense this intrinsic QRS, but also likely oversense this T wave. Other terms you will see, undersensing. This means the pacemaker does not see the intrinsic beat and therefore does not respond appropriately. So you can see here that there's an intrinsic beat. The pacemaker doesn't sense it, and thus it delivers a scheduled pace inappropriately. Versus oversensing, in which an electrical signal other than the intended P or R wave is detected. And oversensing will generally exhibit pauses in single chamber systems. So you can see here that even though the marker channel shows intrinsic activity, it thinks there's a V sense, there's a ventricular beat here, there's no activity present on telemetry. How are ICDs and pacemakers different? The key difference is ICDs need a lot more power to deliver high energy therapies. So they have a capacitor, which can turn a low voltage system into a high voltage system with rapid discharge. The lead is essentially a special pacemaker lead that can pace, sense, but it can also give a high energy shock and sense VT or VF. These are generally more complex leads than you see in a pacemaker. They've got multi-lumen design with high voltage coils, a pace sense coil with outer and inner isolation. So these are much more complex than a pacemaker. The way we program ICDs is a little bit different than pacemakers. One, we always include pacemaker programming. So the patient will be set VVI 40 as a backup or DDD 60, but they also set up tachycardia therapy zones, monitor zones, and therapy. Generally, we have 3 zones for program, say maybe a slow VT zone at 150, a fast VT zone, or a regular VT zone at 180, and then a VT zone at 200, for example. And during each of these zones, we'll program therapy. So maybe the lowest zone will have some ATP and then a shock. Second zone will have some ATP and then shocks as well. And the third zone might just have ATP while charging and then shock therapy. All right, so that's it for our basics section. Let's move on to how to interrogate someone. So first off, when you're on call and you're called overnight, if someone asks you for an interrogation, you need to take a step back and decide whether you even really need to do it. For one, many pacemakers or defibrillators can be just interrogated non-urgently. The reasons to go urgently are predominantly for if the patient has an ICD shock, and the question is, was this appropriate? Are they having VT? Are there any programming changes that need to be made urgently? Or if there's a potential or concern for lead malfunction. When you get called to interrogate a device, you you really need to first ask the primary service to identify the type of device they have. And you must have the proper programmer to perform their interrogation, because each company has their own programmers and they don't intermix. They, for example, a Medtronic programmer will not work on a Boston device. I'll just say with a side note before we get into this, you should really always feel comfortable when you're interrogating a device. Print out the information when you get it. If you have questions, go over it with one of the EP fellows and are attending later, or can always call someone overnight. And so the next question is, what if no one knows what kind of device the patient has? And this happens frequently. Patients do not remember what they have. So option one, there's this handy handout that you can easily Google, find on the internet, that goes over, it's an algorithm for determining the type of device based on chest x-ray, based on the shape of the can, etc. This can be helpful, but can be somewhat frustrating and challenging. Option two, there's actually this new app called Pacemaker ID that is actually really awesome. You download it to your phone, take a picture of the device, and the phone app will tell you what kind of device they have. It works really well. But lastly, if you don't have this and you can't figure out, unfortunately, you may be stuck with a cart carrying all of your programmers to the patient's room. All right, so before you even begin, it's helpful actually to look at any prior interrogations if you have them, because this can give you a background. Has the patient had a lot of VT and shocks in the past, or do they pace all the time or not at all? It's just helpful to have some baseline information before you go in. Not always possible though. And then it's important just to be systematic when you go in. Each of these, I'm going to show screenshots of different devices. On the left here, you have Medtronic, middle Boston Scientific, on the right, St. Jude. I'm going to show them kind of intermix. They all have their own different features and stuff, but in general, give you mostly all the same information. They all, when you hook up the device to the interrogator, will give you the summary screen that has a lot of basic information that you need. And you can get most information, a lot of information, maybe not most of it, from the screen. So we're going to go over these in the next couple slides to talk about what you can find from these screens themselves and where you go to find more information. The first thing to do is figure out what type of device the patient has, what leads they have, and whether they pace. That's a simple, easy, low-hanging fruit to look at. So here you can see on this Medtronic program on the left, and on this Boston on the right, on the left you have a CRT-D device. On the right, dual chamber ICD. Next, you can assess how much they're pacing. So it's just in front of you, this patient here, A paces, V paces 98.7% of the time. Whereas this person only V paces 2% of the time. Next, you want to go and record what the basic settings are. And oftentimes this is not right in front of you. So for example, on Medtronic, you have to click on the parameter button here. On Boston, you can either click on this magnifying glass next to setting summary or the settings here. And I'm just going to pretend like we clicked on the Medtronic button. And here is an example of what you might see. So this patient is at DDDR 60 with an upper rate limit of 110. And then this is an ICD, as we mentioned. So he's got a VT zone of 105 beats per minute, pretty slow. He's got no fast VT zone, and he's got a VF zone at 171. If the device detects tachycardia in the VT zone, it does lots of ATP. Whereas, and you can click on this to like see all the text. And if he detects tachycardia in the VF zone, he gets some ATP, but is shocked. It's important to look at what the underlying rhythm for each patient is when you connect to the programmer. And this is present on the top channel or on the top of the home screen for each of these devices. And you can see you'll get a strip, usually electrograms, either one electrogram with markers, or here for this Boston device, you can get electrograms for an A electrogram, a ventricular electrogram, and you get this shock electrogram on the bottom, which records a more global sort of far field signal along with marker channels. So you can see in this top, you have A paste, bi V paste. Here is an intrinsic A read, but for the most part, this guy is A paste, bi V paste. That's the presenting rhythm. This person, however, is A sensed, V sensed. It tells it to you right on the screen. An important step in any formal interrogation is also determining what the underlying rhythm is. This is only necessary if the patient is pacing at present. So if they're A-sense, V-sense, don't do this. But you need to test what they are doing underneath the pacemaker's pacing. So in general, you need to go to the test tabs on the home page or EP study, it depends on the device. And what you will do is decrease the pacing rate sequentially until they're no longer pacing or temporarily suspend pacing. Always warn a patient before you do this. And if a patient, you see that they're pacing nearly 100% of the time, and you suspect the patient has complete heart block and maybe has a very slow underlying rhythm, generally I don't go below 30, 35 beats per minute. I'll get the rate down there, see that they're slower than 35 and say that the underlying rhythm is under that. Next, you're going to want to look at lead function. And so you can get some basic information on the home screen, at least in this Medtronic interrogation, but for the most part, you're going to have to go to tests or press this magnifying glass next to the leads button here to take a look. And there's three things you want to look for leads function. One is sensing. What is the device seeing? This is often auto measured periodically by the device, and you just need to write it down, but you may need to actively click a button for it to check. Normal in the A, you want greater than 1 millivolt, and V greater than 5. But overall, you really just want stable from prior. You don't want lots of fluctuation in this. Pacing threshold. Sometimes devices have an auto threshold check, though it's ideal to check the threshold yourself if the clinical question is whether the device has a lead malfunction. If they're looking to see why the patient was shocked for VT, may be less necessary. To actively text, you're going to have to go to the tests tab on the device, and essentially you increase the rate on the channel you want to test, increase it above the patient's current rate, and walk down the output until you lose capture. This is something that you may want to get help from a senior fellow or EP fellow the first time you do it. But the goal is that less than 1 volt at 0.4 milliseconds pulse width in both the A and B. And finally, impedance. This is in all devices, just a button click. Like I said earlier, you want this to be stable, somewhere between 300 and 1000, and abrupt changes suggest some sort of lead malfunction. All right, and really, most of the time you're asked to interrogate devices overnight to assess events. And so when you're asked to assess whether the patient had VT or whether their shock was appropriate, you want to open up the events tab on the interrogator and start symptomatically and go event by event. How many events were there? When were they? How fast was the tachycardia? What therapies were delivered, and what is it appropriate? And when reviewing each event and determining whether it's appropriate, the best way to determine this is just describe the events you see on the interval plot. Don't jump to conclusions, walk through everything slowly, print things, show them to other people if you have questions, and look at the electrogram. So we're going to just go over a quick example. So here, if you interrogate this patient, you pull open their events tab, you can see that they've had 1 episode of VF, 1 of VT, and 2 episodes of non-sustained VT. This is the dot plot. If you've never seen one of these before, x-axis is time, y-axis is the interval, and for ventricular, the V to V, it's a closed circle, and for the A to A interval, it's an open square. And so you can see here that the patient is chugging along. Generally, the V and A are going at the same rate. There's some PVCs here, but all of a sudden, the V rate rapidly increases to a cycle length of about 310-ish, maybe 190 beats per minute, whereas the atrial rate plugs along at the same rate. The patient receives some ATP and the tachycardia terminates. And so now A's and B's are 1-to-1. So when I look at this, I say this looks like sinus rhythm with some PVCs, with VT at 190 beats per minute with AV dissociation that is successfully terminated by ATP. Here are the electrograms here. So on the top, you have an atrial channel. Bottom, you have a ventricular channel. And then here you have a marker channel. So again, sinus rhythm with some PVCs. The PVC initiates a rapid tachycardia. Cycle length about 340, 350-ish. Whereas, and there's AV dissociation. This is the continuation of the last slide. Here you can see there's ATP. This is denoted on the marker channel by TP, tachycardia pace. And with this ATP, the tachycardia terminates and the patient returns to normal sinus rhythm, ascends 5V paced. Thus, we sort of confirmed what we saw in the dot plot, that this is an episode of ATP terminated VT. So finally, when you're done interrogating, you're going to want to document. So a basic note of a complete standard interrogation of a pacemaker and ICD should include the device and manufacturer, presenting rhythm, underlying rhythm, percent of time paced and sense in A and B, percent of time in AF if noted, or mode switch episodes for pacemakers, settings, lead data that we talked about, a description of all tachycardia events for ICDs and any changes that you make to the device. All right, let's talk about what if you get called overnight to the OR to reprogram a device or to assess it. So the main issue for pacemakers is that the device in surgery will detect electrocautery and interpret it as a native QRS complex and inhibit pacing inappropriately. The main issue for ICDs is that the device will mistake in BTVF and could provide an inappropriate shock. However, so if no cautery is used, the safest thing is just do nothing, no programming, no magnet. There's not going to be any issue. If the pacemaker, if you call to the OR and they're going to use cautery though, and the patient has a pacemaker, and they're pacemaker dependent, you want to just place or tape a magnet over the device. Magnet will put the patient in DOO or VOO if they have 2 leads, DOO or VOO if 1 lead. And that means the patient will pace the A and the B or pace the V without sensing anything. It's going to be in an asynchronous mode. And this works well in 95% of the cases. However, the patient is in a location where the magnet will not stay, like if they're doing cardiac surgery, you may need to reprogram the device yourself to DOO, VOO. If the patient is not pacemaker dependent, you really ideally want to do no magnet, no reprogramming. The anesthesiologist should have a magnet available, but in general, avoid asynchronous mode if you have to. You'll lose AV synchrony, and there's a very small chance of RNT leading to VF. Low chance, but avoid if possible. For ICDs, the magnet doesn't put them into an asynchronous pacing mode. Rather, it turns tachycardia therapies off. It does not affect pacing. So if the patient is dependent and the surgery is near the device, you absolutely need to reprogram the device rather than placing a magnet, because you risk having them inhibit pacing. So if you're called to the OR for an ICD for a surgery that is in the chest, you want to print out or take a picture of what the prior settings are. And many companies have something called an electrocautery mode, which you just click a button and it inhibits therapies. Otherwise, you need to turn off tachycardia detection, either by you need to turn off tachycardia therapy by reprogramming. And just always remember after the procedure or surgery to turn it back on. Lastly, let's talk about transvenous pacemakers. So who needs one? Anyone with hemodynamically significant bradycardia or AV block, anyone with hemodynamic significant pauses, or something reversible causing any of this and can't go for a permanent device right away. In general, I'd like to avoid transcutaneous pacing unless absolutely necessary. So if the patient's in the hospital and needs pacing urgently, a TVP is much preferred to this. But you can always try to hold them over with dopamine or isopril if they'll tolerate that too. The strongly preferred sites for transvenous pacemakers are the right IJ or left subclavian vein, because they have the most direct anatomic routes for the catheter to pass and successfully land in the RV. The right IJ is generally more preferred though, because it saves the left subclavian for the permanent pacemaker. You can use other sites like the left IJ, right subclavian, but these approaches require that the catheter go through a really tortuous course. And so it can be really challenging without fluoroscopy to assist you. In order to place one, you need a 6 French cordis introducer. Like I said, ideally in the right IJ. You need your pacing wire, the box, a swan sheath, and you're going to need a non-sterile helper. And the goal is to put a single wire lead, balloon tip lead, in the RV apex. You advance the pacing wire with the balloon up until you get consistent ventricular capture. You assess threshold with your non-sterile helper, and ultimately hope to have a pacing morphology on telemetry EKG that has a left bundle morphology with a left superior axis, because this would suggest that you were in the RV apex. Patients then need a chest x-ray and bed rest. For each patient with the TVP, it's well advised to check daily to make sure it's functioning okay. And so to do this, you need to check the threshold capture output every day. On the box, you increase the heart rate via knob 1 such that all beats are paced. Next, you decrease the output on knob 2 until pacing ceases and the native rhythm is seen. This is the threshold of the temporary pacemaker. As soon as you see this though, increase the output back to its initial value. And generally we do this 5 to 10 times the threshold, usually 10 or 15 milliamps, and then turn the rate back to its initial value. The third knob is how to adjust sensitivity. In general, for a ventricular GDP, I'll usually leave this at 2, and I won't really adjust it unless troubleshooting, and then document the threshold, the output, and the underlying rhythm in the chart. All right, so that is all I have right now. I am willing to take any questions by email, or can reach out to me through the ACC or by email. As I said, it's here if anyone needs it. Thank you so much for listening. Hope this was helpful, and good luck in fellowship.